like to introduce our speakers for the day, Steve Barnett and Dr. Mark Hammett from Mackenzie Health System. Steve Barnett has served as a hospital chief operating officer and chief executive officer over the past 17 years. Currently, Steve is serving as the president and CEO of Mackenzie Health System. Mackenzie Health System is a rural critical access hospital in Sandusky, Michigan, and is one of the founding members of the National Rural Accountable Care Organization. Steve has been a member of the Michigan Health and Hospital Association since 2001, served and chaired their legislative policy panel, and sits on the Small and Rural Hospital Council. Steve is a member of the National Advisory Committee on Rural Health and Human Services and serves as a member of the National Rural Health Resource Centers, Technical Assistance and Services Centers. Steve serves on numerous healthcare-related boards, is an assistant professor of Central Michigan University's College of Medicine, and is an adjunct professor at Saginaw Valley State University. He began his healthcare career as a respiratory therapist, went to Oakland University and received his bachelor's degree in nursing, which led to a master's degree in nurse anesthesia from Southern Connecticut State University. He then earned his doctorate in healthcare administration from Central Michigan University. Steve is a fellow of the American College of Healthcare Executives as well. He's committed to designing a rural healthcare delivery system that delivers on quality, does not compromise access, and is efficient. Since 2011, Dr. Mark Hammett has been the medical director of the Departments of Emergency and Hospital Medicine at Mackenzie Health System, a critical access hospital in rural Michigan. Mark earned his medical degree from St. Matthew's University School of Medicine and then completed a master's in business administration from Davenport University, as well as a master's in public health from the University of West Florida. He completed his family medicine residency at Henry Ford Health System in Detroit, Michigan, where he currently serves as a senior staff physician and faculty with the Family Medicine Residency Program. Even though he still practices in Detroit's inner city, he has transitioned the majority of his time practicing at Mackenzie Hospital over the years. Mark serves as an associate clinical professor with Wayne State University School of Medicine, Central Michigan University College of Medicine, and Michigan State University College of Human Medicine. He served as the medical director for the National Rural ACO from 2014 to 2015, in which Mackenzie Hospital was one of the founding hospitals. He has been serving as the medical director of the Greater Michigan Rural ACO since 2016. In addition to starting a position as a medical director for 4 rural Michigan counties this year, he is the Associate EMS Medical Director for Sanilac County and its Medical Control Authority. He is also Vice President-elect for the Michigan Academy of Family Physicians. Mark's professional interests include primary and emergency care, improving the health of a patient population through delivery of high-quality, safe, and efficient patient care. Great. Now I will turn it over to Steve and Dr. Hammond.
All right. Well, thank you, Kim. Can you hear me okay?
I can.
All right. Great. Yeah, this journey that we've been on since 2012 has been pretty remarkable in that we were hard-pressed to find anybody who was engaging in any activities that would reduce the flow of traffic for those patients that typically are seeking drugs. What we really began to notice, and I have to tip my hand to Dr. Hammett, is that we had this problem, like I'm sure most EDs notice over time, that some of the traffic coming through the emergency department is really traffic that could be redirected if we could figure out whether or not they were truly seeking drugs. So we started by just simply asking the question, do we have a drug problem? And this predates really the crisis that everybody is familiar with today, which is in part why I think we had so much trouble finding resources that would help us figure out how to organize and move forward. So we began discussing, how much time and energy gets wasted on processing patients that are simply trying to access drugs. And I think all of us at one point or another who've been in any kind of emergency department or healthcare believe that there is some sort of underground website where people can go and figure out where it's easiest to access drugs. So we wanted to make sure that we could find ways to redirect that traffic. We began searching for examples, and again, we were hard-pressed to find any good examples. Dr. Hammett did run across some policies that have been developed in the state of Washington, and that's really what got us going and allowed us to begin evaluating how we might proceed in Michigan. So once we did a little bit of analysis and determined pretty quickly that yes, we do have a drug problem. You notice in 2010 to 11 to 12, there's roughly a 4 to 6% increase in prescriptions being written, and the slope on that curve is up. So when you look at the 21 million or approximately 21 million prescriptions written that accounted for almost 1.4 billion units of controlled substances, that's roughly 66 units per script, which seems excessive. The next thing, we wanted to determine is Michigan an island? I know we're a peninsula, but are we unique to this problem? And really the answer is no. We found that the problem exists throughout the country. What was disturbing, however, is that in Michigan, more than one narcotic script for every Michigan resident. So that's 107 per 100 residents. That sort of utilization and activity is just unacceptable, and it certainly stresses resources that we're not like any other rural organization. We're not flush with human resources, so we need to be mindful of how we're spending those resources and how we're processing patients through the ED. So the next question is, why do we want to start an Oxy Free ED? Well, as it has been described, we're simply a critical access hospital. We have limited resources like many of our colleagues across the country. Our emergency department bed capacity is only 5. We have an average of about 6,000 visits per year, and we staff with 1 physician, 1 to 2 nurses, and an ED tech. And then, of course, imaging coverage is on call after normal business hours. And what I didn't include in here is that the way we have staffed our emergency department, they serve not only as our ED physician, but they also serve as the hospitalist for the organization. And with that, I think we would do you justice if I hand this over to Dr. Hammett. Go ahead.
Thanks, Steve. So as you mentioned, with 1 physician, around 1 to 2 RNs, and usually 1 ED tech per shift. We have on-call radiology tech who will come in after business hours for CAT scans, X-rays. We have in-house lab. these limited resources, having one patient who presents to the ED complaining of a severe back pain, severe headache, that can take up quite a bit of resources in our ED. And that was just it. We've had patients who would present to the ED with these complaints of headache, severe back pain. And these are very subjective complaints. So after an examination of the patient, it was not uncommon to call in the CT tech for a CAT scan or an X-ray to do lab work, pretty much utilizing the resources that might not be available in-house or that might be diverted from another patient towards this patient. So we want to know what can we do to help stem this problem of people presenting to the ED seeking narcotics, and also to help address this serious problem we have with unintentional overdose and dying from opioids. I personally had a relative who overdosed unintentionally on opioids for a severe spinal cord injury, and he died, leaving 3 young children under the age of 10 with no dad. So for me, it hits a little close to home as well. So in light of that, I decided to do some homework and try to figure out what can we do about this. Is there anything being done already, locally or nationally, to help combat this issue? In the state of Washington in 2010 and 2011 rolled out with a term, quote, an Oxy Free Emergency Department, end quote, where the majority of their hospitals had to follow certain prescribing guidelines in order to remain open as an ED with state funding. So look at this model with an eye on the policies, their initial success, and level of enforcement. I also did a literature review of opioid-related adverse events and trends in the U.S., such as overdose, dying, disability. I looked at other health systems' narcotic prescribing policies and their EDs, their clinics, and health systems all across the U.S. And I also engaged in discussions with out-of-state ED medical directors that shared our concerns and were also in various stages of development of similar policy in their hospitals. So using all this, we developed this policy, this Oxy Free ED policy. Now, we got a symbolic start date of January 1st, 2013. We figured new year, new policy, let's go for it. However, we implemented it a month later, February 1st of 2013. This is because we felt that we were not ready at a staff level to deliver a compassionate message to these patients. We wanted to make sure we were telling patients very compassionately that no, we can't give you opioids for your chronic pain. However, here's what we can do to help you out. Here's resources. You know, we were personally worried about staff finger pointing and having a hard time delivering that compassionate message, because for so long these patients were the ones who would come into the ED in the middle of the night and make a scene, sometimes be very rude to staff, demanding narcotics. So we wanted to make sure this wasn't a sort of revenge, I guess would be fair enough to say, on these patients who for so long were the ones who come to the ED in the middle of the night, demanding narcotics, sometimes being very rude. So long story short, we want to make sure this is a very compassionate message and one that would not turn patients away from seeking care in the ED. Now, while we were developing our policy, I met with some local primary care providers. We talked to them about what we plan on doing. Like, hey, we have an opioid problem in our area, and these patients are ones who normally don't receive primary care. They bounce around from ED to ED or ED to urgent care, trying to get narcotics. Some of them are drug seeking and do abuse it. Other ones just have chronic pain and they don't have established primary care. So meeting with the local primary care providers, I frame this as an opportunity to engage these patients, to see them routinely, to get them under a pain contract where they could come see you once a month for their opioids if they need it, and at the same time catch them in for routine primary care, health maintenance, colonoscopies, pap smears, mammograms, these things that otherwise they weren't getting. We showed an example of what a pain contract looks like and how to enforce it. We also met with law enforcement and our local pharmacies just to let them know our plan so they're all on the same page. I also met with the local mental health and county public health departments to let them know about our policy that we plan on rolling out, and also to see what kind of resources they might have for our patients too. And surprisingly, there was tons of resources that were available that were underutilized by the community, especially in regards to substance abuse and chemical addiction. So that was a very positive relationship we have with them. Before the policy rolled out, we engaged in radio and newspaper media blitzes and announcements. Most importantly, as I previously mentioned, we prepared our staff to compassionately deliver this message to these patients. And that was the reason for the delay of 1 month. You know, we trained using role-playing skits, Jeopardy questions related to our policy. So we did a lot of things in that 1 month time just to prepare for how to deliver this compassionate message to these patients who need help. Now, I'll briefly go over some basic definitions which are relevant to this conversation. There's drug-seeking behavior. This behavior is essentially behavior that looks like it's very manipulative or demanding medications. And these patients can try to obtain prescription drugs by using false names, addresses. And then there's drug abuse. This is use of medication for reasons other than medicinal purposes, which impairs the physical, mental, emotional, or social well-being of the patient. And there are patients with chronic pain and those who truly do need to have their medications. Now, what's a typical patient scenario? Many times it'll be they come to the ED with, quote, the worst pain ever. This could be a headache, a backache, extremity pain, a toothache, you name it. And these are the patients who will come to ED and essentially complain of issues that really need to be worked up, just to rule out any real emergent medical problems. And these take up resources and ED space. Many of them might have illicit allergy to NSAIDs, such as Motrin, ibuprofen, Aleve. And they state the only thing that ever works for them is, Dilaudid, morphine, fentanyl, Vicodin, oxycodone, Lortab. You name the opioid, that might work for them. And many of them will say, don't worry, doctor, I have a ride. Just in case there's an IV or IM opioid to be administered in the ED. Because many policies don't allow administering opioids to patients who don't have a ride home because of the fear of impairment while trying to drive. So these patients are ready, just in case. Now, we do our ED medical screening and rule out any emergent medical condition. And with a few exceptions, patients with chronic conditions are only treated with non-DEA Schedule 2, 3, or 4 substances while in the ED. Patients are responsible for maintaining active prescriptions with their PCPs or pain specialists. We will not give refills or replace any lost or stolen medications. Now, we define chronic pain conditions such as migraines, back pain, neck, pelvic, ovarian pain, dental pain, fibromyalgia, musculoskeletal, as chronic pain conditions. Now, if a patient has had 2 ED visits in 30 days or 6 visits in a year for a painful condition, that will be considered a chronic pain condition. Or if we notice frequent narcotic prescriptions prescribed when we do our MAPS review. MAPS is our Michigan Automated Prescription Search Base, which I'll talk more about later. Now, determining if patients are in acute or chronic pain. Now, if we determine a patient's in chronic pain, we encourage them to follow up with their normal providers, or if they don't have a provider, then they'll be given a list of providers locally in clinics who can accept them on as new patients. If it's determined that the patient does have acute pain that needs to be treated with medications, the ED provider may be able to administer a Schedule 2 through 4 drug in the ED. The patient must have a responsible adult with them for transportation home, and the responsible adult must be with them at all times until the full effects of the drug wear off. Now, if we treat a patient with narcotics at ED and they return to ED again, then those patients will not be treated with any further narcotics. warranted, and they must seek specialty or generalist care. And again, no Schedule 2 through 4 narcotics will be prescribed. Now, when you say someone has drug-seeking behavior as a provider, you better document, because that's a huge deal. You know, saying somebody's drug-seeking behavior might have huge ramifications if you're incorrect. So whatever information you have to go by, you use it. So a good rule of thumb is to document why you think they're exhibiting drug-seeking behavior. You, of course, get your appropriate medical exam completed. You review any blood and urine tests, such as urine drug screen. We perform our Michigan automated prescription search and document the findings in the EMR. We try to obtain any outside or internal medical records that will help us determine whether or not this patient is truly drug-seeking. And also, we document our objective and subjective findings. What the patient is saying, how they're acting, you know, if they say they're in severe pain, and the minute you leave the room, they're bending over to pick up their iPad. That chronic back pain that's severe might not be that bad. You know, anyways, document everything you can to justify your decision making. Our interaction with these patients are very important as well. It's important to use clear, non-confrontational communication with these patients when talking about our policy and the treatment plan. And if we do feel like narcotics are warranted, we'll give a maximum 2 to 3 day supply. We refer patients to the primary care providers or pain clinicians, and we provide other resource referrals such as social services, counseling, behavioral therapy. We recommend the use of non-narcotic analgesics such as local nerve blocks, physical therapy. And for those patients who need chronic pain medication, we recommend a pain contract with a primary care provider or a pain clinic. To go back to that local nerve blocks, I'll tell you, when we have patients in AED who are saying they have severe dental pain, and it truly is severe dental pain, and you tell them, I can inject the medication to help block the pain for 10 hours to give you some sleep, they'll take it. They will. However, those who might be drug-seeking will usually not want the nerve block, or they might get the nerve block and say, well, it's not working for me, when they usually do work, just to obtain a prescription for opioids. In Michigan, we utilize a MAPS system, which is a prescription monitoring program that's used to identify and prevent diversion by collecting information on Schedule 2 through 4 substances. Pretty much, if you're able to prescribe a narcotic, then you're able to query the data for patient-specific reports using usually a name and birth date. The data is stored in a secure database within the Department of Health and Human Services. Prescription data is submitted daily by pharmacists, sometimes in real time, so patients don't, quote, load up between data submissions. Now, a backstory to that is back back when we first rolled out this policy 6 years ago, almost. This was data was uploaded to the system twice a month, on the 1st of the month and the 15th of the month. So those patients who were the true drug seekers who were pros would go to tons of EDs first part of the month, knowing that on the 15th of the month, all those prescriptions will be available to review. So within those 2 weeks, they really, went to different EDs, urgent cares, and loaded up prescriptions. Now, I'm glad to say that Michigan is on a daily submission process, so that makes life a lot easier for us providers. And, it helps catch those patients who otherwise would be really abusing the system. The results of our Oxy Free ED program has been amazing. We had a 60-day follow-up review, and we saw a 60% reduction in prescriptions and no decline in ED volume. A 1-year follow-up, we maintained a 51% reduction in prescriptions. 2-year follow-up, we saw a 57% reduction in prescriptions for narcotics. On the 5-year follow-up, we had a 90% reduction in prescriptions for narcotics compared to January of 2013. In January of 2013, there was 210 prescriptions compared to January of 2019, 19 prescriptions. There was 4,053 opioid pills prescribed in our small ED in January of 2013 compared to 114 opioid pills in January of 18. The most remarkable result is in January of 2013, there was 19.3 pills per prescription written as compared to January of 2018, only 6 pills per prescription. This represents a 70% reduction in pills per prescription, which is amazing. Now, I'll tell you, an interesting fact is that these, quote, frequent flyers in the ED, end quote, who are, drug seekers, we used to call them, chronic pain patients too, these patients would actually come back to the ED, but for acute medical reasons. So no longer was it, my chronic pain, my back pain, my dental pain. They were coming with pneumonia, with abscesses, cellulitis, so medical conditions that otherwise we wouldn't know about because their usual complaint is chronic pain, their pain, they need their narcotics. So we had a little dip in the volume the first month, and the next month they all came back. Word of mouth in rural Michigan is great. Other results that were noted were employee satisfaction increased greatly. So did job satisfaction. We were seeing less of these, quote, frequent flyers and able to take care of patients who truly needed acute medical care. Our Oxy Free ED campaign was discovered by some national media websites, and that resulted in some hospitals calling us up on the weekends to say, hey, can we roll your policy out in our hospital? And it was a pretty cool thing. And being a physician, it's a lot easier to tell a patient no when you have have a policy you can just point to on the wall that says, hey, this is our policy, and it's just easier to discharge them without arguments. And again, we were seeing more quality visits by patients. So again, these patients otherwise would be coming in for chronic pain conditions or drug-seeking behaviors, or coming in for acute medical conditions, which, you know, is a new phenomenon for us with these patients. And overall, it led to a less stressed work environment. I mean, really comparing to how it was before the policy and after, it's like apples and oranges. It really provides for a different ED flow. So there were patient complaints, obviously. This was a good one. Initially, our policy language stated that we will provide you with non-narcotic medication. However, our new policy stated patients that have chronic pain may be treated with a non-narcotic only as a temporary treatment at the discretion of the physician. We may provide you with a non-narcotic. So some of those patients found that little word, we will provide you, so they demanded something for pain, even if they didn't really need it. So our new policy is a lot more clear. It says we may provide you with a narcotic if it's deemed necessary. Now, we were very careful not to violate any MTAL issues. So we avoided using signs